Hello and welcome to episode 2 of Lovegrove on Health. My name is Dominic Louks, Product Marketing Manager at Skills for Health, and joining me is Andrew Lovegrove, Skills for Health Senior Consultant. How are you, Andrew?
Hi Dom, I'm really good, thanks, and really excited to be here again doing another one of these podcasts. I'm so pleased that we're able to record these sessions and looking forward to talking with you today with some of the hot topics that are on the news agenda.
Yeah, it's great to be back. We're now settling on this podcast being fortnightly, possibly with some longer breaks over the holiday season. But just as a reminder to our listeners, each episode will be taking a look at the latest health service news and then drilling down on a particular national workforce development issue impacting or likely to have significant impact on those working in the health sector. So before we shine the spotlight on the topic for today's podcast, which is workforce challenges in primary care, what are the headlines that have most caught your attention affecting the health sector in the past week or so, Andrew?
So I think following on from our first podcast where we were talking about the no jabs, no jobs and the potential review of government policy, I think it's looking increasingly likely that the no jabs, no jobs rule will be relaxed in health. Bit of a U-turn on this policy. And I think the impact of that is going to be felt for some time to come, because there will be people who have felt incredibly vulnerable about the prospect of either being moved to work in another area or in fact even losing their jobs. That's now less likely to happen. But what's that done in terms of the psychological contract between employer and employee? It was probably, if implemented, a fairly brave policy decision, because the projections were there on the types of numbers we were likely to lose from the front line. But I think, there is still a legacy of people perhaps feeling marginalised or disenfranchised by this policy, even though it hasn't been enacted. There's also the impact it's had on the care sector, because obviously they went before in terms of no jabs, no jobs. And even if that's reversed, there's always been this sense of discrepancy between health and care. Health gets all the glory, gets all the plaudits, and care is seen as the poor relation. And for those of you who are old enough to remember the implementation of the poll tax back in the early 90s, the Tories decided to pilot that up in Scotland. And the impact of that is the Tory vote was always decimated and has never really recovered. And I feel some parallels with health and care that, we'll try this in care first because, care doesn't quite matter as much as health. So we can afford to lose those people if they've not been jabbed. And for me, this has just been, that myth's been perpetuated. And I worry about the impact it has on the care sector itself, but also recognising that without the care sector, the NHS and the health sector cannot function properly and as we would like it to do, because either people end up being admitted to hospital when they don't need to, or when they're ready to be discharged, there's nowhere for them to go because social care cannot accept the volume and complexity of patients that hospitals and the health sector are looking to discharge from. So, I think projections, was it the Nuffield Trust said, up to 40,000 had left the care sector within 6 months.
Between June and December 2021.
Are we likely to get those people back? We may get some back, but I'm going to say it's doubtful we'll get them all back. So we've got, a very pressurized care sector, at the time when health is really struggling with the capacity issues and the volume of patients and the throughput. So reversing the policy, is it welcomed? On balance, I'm minded to say yes, but just because we've reversed the policy doesn't mean the impact of what it was going to do will not be felt. And I think that's something we want to keep an eye on over the next period of time.
Yeah. Do you think the policy actually had good intentions at all? Because you actually look at back when the lockdown was happening and there was the essential workers list, there wasn't too many other roles on that list where mandatory vaccination was a requirement.
Yeah. And, if I was coming at this purely from, I suppose, a scientific, a purist and epidemiological perspective, I could say the policy was well intended. But I remember what my grandmother used to tell me about, that the road to hell is paved with good intentions. So it's another example of where we need to think about the impact of policy. So the intention is good, but what's the impact of that policy going to be? And I think, that's a theme that we'll probably come back to on several occasions, because I think my critique of a lot of policy is it's well intended, but I'm not sure the impact of it has been fully assessed and thought through in the round. And that maybe has something to do with, do we involve the right stakeholders in the formulation of policy at the right time? And to what extent is this, big P politics pushing an agenda, as opposed to actually what are the requirements and what do the experts within the relevant sectors have to say on this policy issue?
Obviously, we can't not talk about the latest sector news without the record waiting list numbers that were published last week. What's your thoughts on that particular news story?
Well, I mean, the highest numbers since records began. The figures, I think, are projected to reach 10 million on the waiting list by the time that the latest election date can happen in 2024.
Yeah.
I guess it's an inevitable consequence of what we've been through for the last 2 years, that we've been so focused, and rightly so, on COVID treatment, COVID recovery, in the sense of people recovering from COVID. That's going to still continue, even if we are at the beginning of the end, or the end of beginning of COVID moving to a more endemic phase. Things like long COVID, other unforeseen circumstances that are going to arise as a result of COVID. So I think the waiting lists, the figures that we've got, I would say they are the best case scenario figures out there. I think they could spike even further, because we're still not quite sure on the level of the unknown demand. I was watching, I'm really, really sad, Dom. I watch all the programs on television that, cover hospitals and A&E departments. And I was watching a program the other night about, it was a guy who'd had this sort of low-level chest pain for a period of time, and thought, as a lot of men do of a certain age, it's just a niggle, it's just a pain. I won't bother anybody about this. I won't, I don't want to cause any trouble. I see A&E departments on the news. I don't want to be another burden. But actually, when he eventually, I think it was his wife, strong-armed him to attend hospital, he'd actually got a really underlying condition that, frankly, if had gone unchecked for much longer, he was looking at a very, very poor outcome, shall we say. And I think that's just the tip of the iceberg of, we know the people who are already on the waiting list, and we can project that to a certain degree, but how much unmet demand is there? And not just thinking about physical health. I know the cancer diagnosis appointments are extending beyond the 14-day target. I think about, what are we storing up for ourselves in terms of demands for mental health services, who are on a good day stretched at best? The impact that people have experienced of living in this 2-year period of almost constant anxiety, constant tension, locked away in their homes. What's that done to people's coping mechanisms? Thinking about children and young people, what have we done to children? And we won't really know that, immediately. How's that going to manifest itself in time? I hate to equate children to animals, but friends of mine had a new dog during lockdown, and they were at home all the time. They've now gone back to work, and they've got a dog with separation anxiety. Yeah. We've instilled in children this, be fearful of the outside world. what's that going to do in the long term? I'd be really interested to know what, people who are specialists in this area have to say, because I don't think we fully know what the waiting list and the demand as a result of COVID is going to look like, alongside the ever increasing demand we have. The NHS demand for service goes up year on year anyway. So I think it's another one that will be one to watch. I'd absolutely say the situation's going to get a lot worse before it gets a lot better.
Yeah, I think that could be a potential studio guest for a future podcast, but I think you're absolutely right. It's also the psychology, because I think people will start reading about these waiting lists and just instantly deter from seeking medical advice, just knowing that nothing's going to happen immediately.
Yes. And the kind of the perverse outcome of that is the time, to use another of my grandmother's famous adages, prevention is better than cure. So not accessing services sooner, seeing how you go, very often, leads to poorer outcomes for you as an individual, but also may mean you need a higher level of intensive support from the sector. But I totally get what you're saying there, Dom, that, you see the newspapers, you see the news, you see the ambulances backed up outside A&E. You do think to yourself, oh, should I really? Can I wait? Sometimes the answer is yes. I mean, this is the thing. Sometimes the answer to that question will be yes. But a lot of the time the answer is no. But I wonder what people are doing out there in terms of accessing services when they actually need to access them.
Yeah, I just hope that they're not Googling, because that's
absolutely
depressing.
I look, as a former registered nurse, I never used to have a headache. I was having some sort of, hemorrhage, or, every time you pull a muscle in your arm, you think to yourself, oh, am I having some sort of cardiac episode? So internet research is great on one level, but that's another topic of conversation in itself, Dom.
Absolutely. And I suppose perhaps one other final news story worth covering, which looks like the government are potentially looking at ending the self-isolation for COVID, may even be as soon as the end of this month, and perhaps what your thoughts are on that potential policy change.
I guess when I heard the policy announcement, well, first of all, I wasn't sure if it was a policy announcement or if it was just a statement of intent initially. It was all kind of shrouded in parliamentary obfuscation. My initial reaction to it was, is this less about the science and more about the political science? Thinking about some of the pressures the government is facing from its own backbenchers at the moment, and a general desire from the centre and the centre-right rather to take a more libertarian view of the world, and the government's had to make a political calculation. I think there's a kernel of truth that we perhaps need to think about, that awful truism that's been established, the new normal. So unless we are going to live in a perpetual COVID, lockdown scenario, in the long term, then we probably do need to think about how we readjust the barometer. Personally, I would have waited another month. I think at the end of February, we're still in the depths of winter in terms of the winter pressures. I mean, having just said that, it feels as though winter pressures are now annual pressures. But I think by the end of March, the needle is starting to shift away from the depths of winter. So I would have personally waited another month before I readjusted things. But again, the government may say, look, we took a slightly less than cautious approach in December. It paid off. We think doing what we do in February will pay off again. So we could be sat here in a month's time, 6 weeks' time, saying, actually, it was the right call to make. Personally, because of going back to some of our previous questions, because of some of the pressures that we're facing anyway, it might have been prudent to wait a little bit longer. But I think time will tell. I think other countries have taken different approaches.
Yeah, I was going to just say, there was a point you made on the first podcast in terms of the virus not knowing about borders. And it just seems quite strange that you've got countries in Europe that are starting to open up, Sweden perhaps even suggesting that they're going to end restrictions and even testing. And obviously Japan is extending its COVID restrictions. Hong Kong is seeing record number of COVID cases now. So it just shows how disjointed globally the picture is now, and what impact that will be over the coming months.
Absolutely. And I think in the first podcast, I talked about the spectrum of lockdown. So you've kind of got Sweden at one end, Japan at the other, thinking internationally, everything that's happened in Canada in the last week or so. So it's where the UK and the four nations within the UK, where we sit on that spectrum. I think it goes back to the point I made. There's no right answer here. I think what we have to do, though, is be able to have a degree of flexibility that we can cope with the circumstances that we're presented with. Hopefully, we're making the right decision. But, I think I've said this already. I would have perhaps waited another month before we made the change. Psychologically, we put the clocks forward at the end of March. Feels like we're entering, better times, better weather, lighter evenings, all of that. But we'll have to wait and see.
Fabulous. Great news recap as always. I still think we should do a podcast just on news. But anyway. So going on to our main talking point for today, which is we're going to be talking about workforce challenges in primary care, which obviously is a critical part of the health sector ecosystem. It's where 90% of patient contact takes place. So with that, question one, what do you believe to be the most underlying workforce planning challenges in primary care today?
Well, I could answer that question. In fact, I'm going to sort of break it down into a number of parts because there's a lot within that question. I think some of the challenges primary care faces from a workforce perspective are not as a result of COVID. I think COVID has probably exacerbated some of those challenges, but a lot of them have been around for many years, and we've built up some of the challenges we face. And I think that's been largely down to we've put things in the too difficult pile. We haven't thought about workforce planning, workforce development in this space for a long time and in the way that we perhaps ought to have done. So I think we're dealing with, it's kind of like pass the parcel. We're dealing with challenges today that have landed in today's people's lap, but they're not necessarily a result of their actions or omissions. I think primary care is reaching a pinch point in terms of its demographics. I think you look at the average age profile of key staff within primary care, they tend to be older than, say, the average age profile of staff, say, working in acute care and hospitals. And there's some reasons behind that. But I think there's been some real challenge, I know for doctors particularly, over things like their pensions. And I don't want to go into an NHS employer's podcast, but if they work overtime, that actually has a disincentive for them. So, a lot of highly qualified staff looking to retire when they can to not continue beyond a certain point. So I think there's issues there that are a result of unintended consequences of policies elsewhere. So it goes back to our point in the news item. I think primary care, there's a bit of stigma attached to primary care. It's very often seen as the whipping boy. It's almost, I remember a comedian from my childhood, Les Dawson, who used to make all the mother-in-law jokes. It almost feels it's become acceptable to make jokes about doctors, receptionists, and, the lazy or errant GPs. There are certain tabloids who every other day or every third day have got an article about, problems accessing primary care services, appointment's not available, lioness receptionist wouldn't allow me to get an appointment. So actually, it's not a particularly, appealing place for lots of people to come and work. There's a lack of new talent, perhaps entering it as a result of that, but also, again, some of the structural challenges that we've built up. A lot of GP practices still work on the partnership model where, if you want to be a GP, you have to buy into the partnership and be, literally a partner of the practice. Well, looking at the way medical training has changed, the fact that you have to pay, your tuition fees, the fact that, the cost of living challenges that we're all facing means that people aren't always necessarily able to buy into a practice. And then practices have to think about, well, how do we sustain ourselves as a business? Do we employ GPs directly? Again, that has all sorts of complications. The fact that we just haven't trained enough GPs in recent years, and the lead time to do that, even if you start your medical training today, you're looking at the vast majority of a decade before you'd even be ready to enter the workforce as a GP.
It's that long.
So you've got your 5 years in sort of medical school, your 2 years minimum sort of foundation training, and then your specialist training on top of that. So you're not going to make short-term decisions. I hate mentioning the word Brexit, but even though GPs would be eligible to come and work in this country from EU countries, have we created a less than welcoming atmosphere to come and work in the UK? I'm not questioning the decisions that we've made. Those are the decisions we've made, but the impact of them, are we not as attractive as we perhaps once were? There's global demand for health staff, so we're competing internationally in a very competitive place. Thinking about nursing, I can just remember when practice nurses were a new thing, and it was seen as, a real, my gosh, nurses working in primary care, working in GP practices. It was quite avant-garde, where now they've become part of the team. You couldn't imagine a GP practice not having practice nurses. But then I reflect on my own training to become a nurse. I did 3 years training. I never spent a moment in primary care. The closest I came was when I was out with the district nurses for 6 weeks, and we would have to call into the practice to get a prescription signed, because these were the days before we had nurse prescribers. So we needed a GP signature to prescribe some dressings. And in 3 years, that was the closest I'd got. And I know that's not quite it's not as extreme now as it was then. But when we look about, training over a 3-year period, do we really promote primary care as a career option? And there's lots of custom practice around. I remember I became a health visitor, and I remember being told, oh, you must be qualified, a number of years before you could ever work in that field. And it wasn't seen as an attractive or exciting place for pre-registration students. It was like, well, you need to go somewhere else, and then when we're ready for you, you can come and work here. And what used to happen is people then had exciting careers in acute services and kind of forgot about primary care. It was that place where I wasn't made to feel particularly welcome. So there's issues around, do we promote primary care and GP practices? I'm pleased that Skills for Health has done some work in this space in the last couple of years. We've developed a capability framework for advanced clinical practice for nurses working in primary care, just to show that practice nursing isn't, again, that stereotype of, oh, that's the person who does your immunisations, or that's the person who takes my stitches out after I've had an operation. It's actually a place where you can be a highly specialist, experienced clinical practitioner and can really extend your skills. And so to support that, we're hoping, in fact, it's written, we're just waiting for NHSE and I to launch it. We've developed a career and capability framework for primary care and general practice, which shows actually you could start your working career in this space as a healthcare support worker, a nursing assistant, and could actually work all your way through to being a nurse consultant in primary care. That career pathway is there, but we need to promote it. We need to sell it. We need to show that it's an attractive place to work. And I think historically, we just haven't done that.
Fascinating. That was really interesting answer. Thank you, Andrew. So following on from that, do you actually think the additional roles reimbursement scheme, well known within the industry as ours, will have a significant impact on relieving some of the pressure on these workforce supply concerns that you've just mentioned?
Potentially yes is the short answer, but it comes with a however. I think anything that can support new ways of working, new roles as a workforce development specialist has to be welcomed. However, going back to intention and impact, obviously the additional roles and responsibilities, or let's just call it the R's for shorthand, has had some unintended consequences. So the R scheme basically allows primary care organisations to employ certain roles, and there's a list available of what the roles are, but two of the most common roles have been around a clinical pharmacist and a paramedic. Those are two roles that are most often utilised in the R's scheme. And what we found has happened is people have rushed to bring in those posts in their settings to make use of the reimbursement scheme. And it's kind of like, we'll get them in, and then it's like, so how's it going to work? What are we going to do with these individuals now we've got them in? And my golden nugget as a workforce development specialist is you need to work all of that out before somebody starts on day one. One of the biggest failures of new roles, new ways of working is not working out how that role will interface, hand over, hand off with the existing primary care team. And a little anecdote, I was down, Workforce Development Trust has its headquarters in Bristol, and I live up in the northwest of England. And I was down at the end of last year for a day in Bristol, just before we went into kind of the Omicron lockdown. And on the journey home, I was sat on a half-empty train, and on the table across from me were two GP registrars, so two existing medical doctors who were doing their specialist training to become GPs. And being the eavesdropper that I am, listening to their conversation, and they were relaying their experience of, oh, the practice I'm in, we've got one of these paramedics, and nobody really quite knows what they're supposed to do, and what they're allowed to do, and actually how are they going to make a benefit? Are they just getting in the way? And I couldn't help but then get involved in the conversation because they had no understanding of the R's scheme, what its aims and its intentions were, but they were very much living the impact of somebody who'd been brought into the primary care team, but nobody had kind of done the workings out. They'd got to the equals sign and the answer was 42, but they hadn't really done that working out. So, and we're doing a piece of work at the moment in London around supporting primary care workforce planning. And we're seeing people who initially had some success with the R scheme. They recruited people in and they came, they started, but then they've left they've gone elsewhere. And there are other reasons why those individuals have left, but a lot of it has been around their role, and the impact or the outcome of their role hasn't been thought through. They haven't thought through how the role's going to integrate. I'm going to mention the G word now. They haven't thought about the governance of that role, and so it's not seamless. And so people, it's like, just imagine, Dom, you come to work and all you get from people is, so what are you here to do? What's your job? You're like, well, I don't know. It's my first day. I was hoping you'd tell me that. It doesn't create a particularly conducive atmosphere. And also, if you're going to recruit people in, think about where they're going to work from. I was speaking to somebody from the capital who'd come to work for a practice, and there was literally nowhere for them to work from. They hadn't thought about, okay, we want them to provide a clinic. What room are they going to work in? Have they got the kit that they need? So, when you've got that on top of, you've been made to feel welcome on a personal level, perhaps, but not made to feel welcome on a professional level or a working level, would anybody stay in the long term?
Why don't you think that sort of background planning isn't taking place? Is it because the scheme's quite competitive and it's sort of first in, you get the funding, and then they sort of think about the consequences later? Is that it?
I think there's an element. I think there is that kind of first up, best dressed. Each primary care network, there is a fixed allocation of funds available. It's not an inexhaustible supply. And again, I think people their intentions have been, well, if we get somebody in, people thinking, the challenge will be finding the people. So if we're the first to market, we'll get the people in, then that's the problem solved. And then we'll do all the working out behind that. But that's kind of a very short-term success, because, okay, you bring them in, you've got your tick in the box, but then that success, then peters away quite quickly if you've not done some of the structural thinking. The R's funding is linked to specific roles. So, for example, as it stands at the moment, you cannot use that funding pot to bring in additional nursing capacity. It's not eligible. It's only around certain other roles. So actually, your workforce requirements, if you haven't done an analysis of what your workforce requirements are, it may be that a paramedic may not be the answer to the problems that your practice population is facing. But you're kind of left with this conundrum of, well, if I bring in a paramedic, I can get funding to support that. If I bring a nurse in, there's nothing other than the money that's available within the existing budget. So that kind of creates some interesting incentives for practices. And let's be honest, GP practices, the vast majority are, as we've said, are independent providers. They've got to be solvent. If they're not solvent, they won't be in business. So you can see why people have thought about, there's a funding stream available, let's make the most of it, but haven't perhaps thought through the wider challenges. But to be fair, for a long time, see, workforce planning, primary care hasn't particularly had to get involved with it in the same level that, say, an acute trust or a hospital or a major secondary care provider has had to workforce plan, because effectively practices have been standalone organisations that have basically dealt with less than 20, 30, however many employees, so haven't had to perhaps think about workforce planning in the same way. As they're moving to work in a more of a network level, then needing some sort of network level plan is probably the right environment to think about workforce planning more in a more structured way. But we have to recognise GP practices, even PCNs, don't have huge HR and workforce development departments. So they have to apply the theory of workforce planning and development in a way that works for them. And, some of the work that we've been doing, like I say, in the capital, has been helping to create that environment, to build that capability and capacity in order to try and prevent making some of the mistakes that have happened, say, around the Rs funding. So, yes, I think the Rs funding is a solution, but it's only a solution if it's applied correctly and thinking through some of those wider considerations.
Brilliant. I was actually going to save this question, but we're going to use it on our second episode. So I don't know if Savage Avid subscribes to our podcast. Many do, even after one episode. But if you were health secretary, what would you do in this space to fix some of these problems we've discussed today?
Oh, what would I do? Somebody once said, Andrew, if there was more than one of you, you could destroy the world. So perhaps it is a scary thought. But no, in all seriousness, I think, what would I do? There's lots I would do, but just to try and sum some of it up, I think I would be looking for a more outcomes-based approach to delivery. So from a workforce, we often talk about workforce planning as X number of GPs, medical staff, X number of nurses. If we get those in, that will, that's the problem dealt with. Well, that's a bit too simplistic in my view. As we think about the nature of care changing, what is it that our population actually needs? And I would be looking for a demonstration of how we plan and develop our workforce to meet those needs. I still think we need doctors and nurses. I'm not saying we don't need doctors and nurses, but I think it's too simplistic to say 5,000 of these, 20,000 more of these, and that's problem solved. So I think we have to think more about the outcomes rather than the inputs in terms of our approaches to delivery. I think better assessment of, I'm calling it interdependencies across the system. But I think what I mean by that is if we're going to tinker, transform one element of a service, we need to consider the impact that has on other services, because no one element of the NHS and the health and care sector works in splendid isolation. And sometimes we make a decision here, and it's a bit like the stops on an organ. You push one stop in and three other stops pull out. And sometimes I think we need to take a step back and look at the picture as a whole. I know as a politician, I could probably never do this, but I think we have to think about health in the long term and not just think about it in 4 or 5 year election cycles. But me just saying that probably qualifies me out from ever being a politician and the Secretary of State. The one thing I think we should do is to focus on prevention much more. As a health visitor, I can hear my lecturer at university saying to me, for every £1 we spend on prevention is £7 saved on treatment later in the day or later in people's lives. And I think we see prevention, we see public health almost as one of those nice things to do. But actually, I think if we deal with things sooner rather than later, I think the technical way of describing that is, dealing with demand upstream. I think I would want to focus our attentions on that and stop people from getting as poorly and requiring more intensive treatment. And I would want to have a real focus on prevention, public health, and health promotion. I think that has to be the centerpiece of what we do, rather than an added periphery, something nice that we do when we've got 5 minutes.
Is there one particular area of prevention that you would most focus on? Would it be sort of drug dependency or child obesity? Is there one that you think's more critical?
I can't claim to be completely neutral on this, because I know the work you do with young families is absolutely critical. So I think working with people as early on in their lives, the better the outcome. Let me give you one example. So one of the things as a health visitor I used to do was do a child development assessment of a child when they were around 2.5, 3 years old. And that's, for example, when we would pick up any potential problems with speech and language development. And the theory, the evidence tells us the sooner you deal with speech and language delay problems, the less likely, well, let me turn that on its head. If you leave it unresolved, that child enters mainstream school with a speech and language delay, they are almost certain to remain behind or not to exceed in the way that they could had they had the intervention before they started school. And there's a bank of evidence that shows children with poor educational outcomes leads to poorer health outcomes. They're more likely to end up in the lower stratas of the income distribution. So focusing on health at a young age, which, you know, what speech and language got to do with coronary heart disease, you know, in your 50s? Actually, an awful lot. So I would advocate we need to work more with children and young families. We need to use that as the basis for promoting health and looking to reduce health inequalities. Probably why I became a health visitor, because it was something I was so passionate about. But again, it was a service that if ever an organisation wanted to make cuts, we were always one of the first services in mind to make the cut on, because actually, well, of course, we need to fund community nursing, district nursing services, because they are critical. You're just seen as the nice to do. I would really challenge that. And if I was Secretary of State for Health, that is something I would absolutely press for in terms of policy. But we need to think about the policy in the round, because as I've said earlier, policy can have unintended consequences.
Absolutely right. I think prevention, it's always difficult to show the savings that you've made, isn't it? It depends whatever part of industry. That was really fascinating, Andrew. Thank you again. Our podcast is now listed on all the major podcast platforms, including Spotify, Amazon, Apple, and Google, where you can also subscribe so you never miss an episode. The recordings can also be found on the Skills for Health website and our social channels. So until next time, thank you very much for listening.
Bye.